Thanks to all the audience who follows our broadcast. We are live on the first day of the 2020 International Web-Based Neurosurgery Congress. Remember, we are streaming on YouTube Live too. Today, we are pleased to welcome Dr. Juan Fernandez-Miranda. Dr. Fernandez-Miranda is a prominent neurosurgeon from the Stanford University Medical Center. He is professor of neurosurgery and medicine, surgical director of brain tumor, skull-base, and pituitary centers, and director of the Neurosurgical Training and Innovation Center, NeuroTrain Center. Today, at the IWBNC, Dr. Fernandez-Miranda is going to share his lecture, a stepwise anatomically-based resection of medial wall of the cavernous sinus, a game-changing technique in pituitary surgery. Welcome, Dr. Fernandez, and thank you. Microphones are all yours. Bienvenido.
Thank you very much. Thanks for inviting me. This is a great pleasure to be sharing with you this time. And I congratulate you for this excellent symposium you guys put together. Un saludo a todos los amigos en Colombia y en toda Latinoamérica. Y gracias por su atención. Espero que les sirva de utilidad mi charla. So first, I just need to disclose my conflicts of interest, which actually are relevant to this talk. I'm a consultant for KLS Martin, for who I designed this set of dissectors that I use for the operations you're going to be seeing today in some of the videos. For those of you that don't know me, I am actually from Madrid, Spain, where I was born, raised, and I did my original training in neurosurgery. To that extent, I'm a proud Spaniard, as you can see here, of all the good things in Spain. When I was a very young resident, I was deeply impacted by the teachings of Professor Evandro de Oliveira and Professor Roton, and their leitmotif of surgical neuroanatomy being the most important knowledge that we need to acquire as neurosurgeons. When I saw a picture like this from Evandro many years ago, this is a transcavernous posterior canalodectomy approach to get to clip a basilar aneurysm. This is such a complex operation, but if you look at the anatomy that is displayed in the lab, it looks so similar to the anatomy in the operating room. And this showed me, at the very early stage of my training, that anatomy is the most important knowledge that we need to acquire as neurosurgeons. And it was Professor Evandro Oliveira who better highlighted this and who deeply influenced me in trying to pursue a career focused on microsurgical neuroanatomy. And because of his help, I was so privileged to join Professor Roton and work with him in the lab for 2 years. And those 2 years really changed the way I develop my career and I do my operations. Dr. Roton's lemma was to perform perfect anatomical dissections because we want to do perfect surgical operations. And that's why the dissections you all know from Professor Roton's lab are so pristine. They look almost like masterpieces. And to some extent, we want to do an operation that is just like that. Because knowing the anatomy is what allows you to do a very complex operation actually look simple. And when you know the anatomy, you can predict where the structures are going to be before you see them. You can actually enjoy your operation because you know how to move around. You know where to cut, you know where not to cut, you know where to look for the anatomy and where to look for the structures. And this is no question the key for a successful operation. And it doesn't matter if you're doing endoscopic endonasal or open skull-base surgery or brain tumor surgery or vascular surgery. It's all about deep understanding of the surgical anatomy. After my time with Professor Roton, I joined the University of Virginia for a clinical fellowship in cerebrovascular surgery, and I was so fortunate to learn from all these giants in neurosurgery. And in particular, I was very impacted by the pituitary team at UVA, both Dr. Oldfield and Dr. Jane. I was deeply impressed by Dr. Oldfield's technique for Cushing's disease and his microdissection skills and his meticulous, beautiful technique for this operation. And I started seeing the endonasal approach and the potential of this technique from Dr. Jane. And from here, I had the opportunity of a lifetime to join the Pittsburgh team at that time led by Professor Kassam, Karan, Snyderman. And it was such a privilege for me to join them and become part of the team in Pittsburgh. To me, it was the best skull-based team ever, and I was so fortunate to learn from them many of the things you're going to see. I believe one of the things, the main reasons why the Pittsburgh team, let me join them is because at that time, 2008, 2009, intranasal surgery had already evolved a lot from the Pittsburgh team and some others around the world, but the foundation of anatomy was still not solid. And to develop a new technique, you need a really solid foundation on the principles of microsurgical anatomy. So we spent the following 10 years, along with my colleague Paul and Snyderman and Juan in Pittsburgh. And during that decade, I believe we did a lot of work, both in the lab to establish a more detailed microsurgical anatomy for endoscopic intranasal surgery, and also training people from all over the world through courses, through research fellowships, and through multiple publications, so we could widespread the use of endoscopic intranasal surgery in the safest and most efficient way possible, which is basing it on good understanding of the anatomy. It was 2 years ago, approximately in 2008, when I was recruited by Stanford Neurosurgery to lead the skull-based program here, and this was a huge honor to join this stellar team. This is my ENT rhinology team for endoscopic intranasal surgery, and also for lateral skull-based surgery and oncology, and also very especially endocrinology with, again, world-class colleagues here at Stanford. What I want to show you today is I want to focus on this topic, which is the resection of the medial wall of the cavernous sinus. Because I believe I'm going to share with you some knowledge that is new, and is new for me, and I think is new for many, things we're learning along the way. 3 main points. One is that I'm going to show you how adenomas invade the medial wall of the cavernous sinus much more often than has been previously reported. And the invasion rates actually depend on the tumor type, on the cell lineage of the tumor, as you will see. Second, the removal of the medial wall may significantly improve remission and total resection rates. And I'm also going to try to show that to you. And third, the medial wall removal is safe when it's performed by highly experienced surgeons. It can be done safely, but it is a very steep learning curve, and this needs to be taken very seriously. Let's start by understanding what is the medial wall of the cavernous sinus. As you know, the pituitary gland has 2 layers of dura. The outer layer is the periosteal dura, and the inner layer is the meningeal dura. When you go to the edge of the cella, these 2 layers just bifurcate one from the other, and that bifurcation creates this space, this pocket, which is the cavernous sinus. In a way that this membrane here, the periosteal layer, forms the anterior wall of the cavernous sinus, and the medial wall is, or the meningeal layer forms the medial wall of the cavernous sinus right here, and both are single dural layers, anterior wall and medial wall. This is a very simple concept, but it all starts from this very simple concept. You separate both layers to go into the cavernous sinus. When you look at an MRI, for example, this is a case right here, and then you see this is the medial wall of the cavernous sinus. You can see it here, but from here you cannot predict whether this wall is going to be invaded or not. And imaging is not going to help us determining that. So I'm going to show you the things we've learned over the last couple of years doing these things. So this is the medial wall in here. This is a case I did almost a decade ago in Pittsburgh, and it was a enlightening case. This tumor is right here. It's a small adenoma. It's a recurrent tumor. And then when I dissected the pituitary gland, I was expecting to find the tumor in this area of the pituitary, but I did not find the tumor. However, I found thickening in the medial wall of the cavernous sinus. So I separate the meningeal layer here from the periosteal layer to go into the cavernous sinus, and that's where the tumor was. And after some work, I was able to just remove the medial wall completely, and you see the tumor is embedded in this medial wall. So these tumors can actually grow in the dura of the medial wall of the cavernous sinus. This was the first time I removed the medial wall, the first time I saw or I had proved that this invasion of the medial wall of the cavernous sinus by tumors. Now, this is not new. Dr. Oldfield in his amazing experience with ACTH adenomas, he showed this in a number of cases, and he actually described his technique for medial wall removal, as you see in these beautiful illustrations here. You can see the small adenoma and how he cuts a bulb below, and he removed this in block, as I just showed you. And before our study, this is, as far as I know, all the technical details we had on removing the medial wall of the cavernous sinus. There were other reports, and this is a very strong group from Tokyo that I met recently. They published this in 2014, 150 patients with acromegaly, impressive numbers, with 85% remission rates, extraordinary. And in their cases, they had 18 patients where they removed the medial wall of the cavernous sinus. So they were really doing removal. You can even see a picture where they are removing the medial wall of the cavernous sinus. But still, there is no technical description, no good anatomy to follow and to learn from. And that's why, you know, over the years, we went to the lab and we studied this very carefully. What is the medial wall? What is the anatomy? What do we need to understand to remove this medial wall safely? So you look at the outer dura and then the inner dura right here. You can see the medial wall, the single layer of meningeal dura, has all these ligamentous attachments that go from the medial wall to the carotid, or to the medial wall and to other walls of the cavernous sinus, or behind the carotid into the clinoid, anterior clinoid process. So we started studying these ligaments carefully. And the first one that is so important is this one right here. This is so-called the carotidoclinoidal ligament, and is the ventral proximal dural ring. What that means is this ligament goes from the medial wall of the cavernous sinus, attaches to the carotid, and then, as you see in this illustration, goes behind the carotid and attaches to the undersurface of the anterior clinoid. This is the proximal dural ring. What happens is this, we see it usually we remove the anterior clinoid through an open approach, but that would be the dorsal proximal dural ring. This is the ventral aspect of the proximal dural ring, but it's the same ring. What that means is that the carotid that is above this area, this segment of the carotid, is the clinoidal carotid artery, and whatever is below, this is the cavernous carotid. And this carotidoclinoidal ligament forms the roof of the cavernous sinus, proximal dural ring, and is the superior attachment of the medial wall of the cavernous sinus. If you want to remove the medial wall of the cavernous sinus, you need to understand this ligament and transect it right here. In fact, we're seeing more and more tumors invading actually the ligament, and you have to cut this ligament. And as far as I know, this had not been described before, not the relevance of this ligament. If you cut this ligament, what you find behind is this other ligament, the interclinoidal ligament that goes from the posterior to the anterior clinoid, a very well-known ligament. And I know in surgery that I have removed all the medial wall when I find the posterior clinoid and the interclinoidal ligament attaching to it. But we also found another very constant ligament. This is the inferior paracellular ligament. We call it inferior because it's directed inferiorly in front of the carotid. And this is usually the first ligament you find when you open the anterior wall of the cavernous sinus. And the first one you need to transect, so you can make your way into the cavernous sinus and separate the medial wall. It's also important because behind you have this artery. This is the inferior hypophyseal artery. And this is perhaps the main danger when you do this approach. Injuring this artery is not really relevant. This artery, we actually studied, even you coagulate both sides, there are no repercussions to the function of the gland as far as we can tell. But if you avulse the artery from the carotid wall itself, you can get a hole in the carotid and you can get significant arterial bleeding that might be difficult to control, especially if you are doing this blindly with not good exposure or technique. So when I see the inferior hypophyseal artery, I do not hesitate to coagulate and cut it, because this allows me to mobilize the carotid laterally and get further space to go into the cavernous sinus and remove the medial wall. We found other ligaments less common, and there are multiple variations, but there were two that were more constant: superior paracellular ligament, inferior paracellular ligament. This one in particular, sorry, posterior paracellular ligament. This posterior one is usually just difficult to differentiate from the inferior hypophyseal artery, just next to it. So when I'm going and working posteriorly behind the posterior of the carotid artery, I always coagulate first before I cut, so I could actually accurately control the inferior hypophyseal artery. So as a summary of our study, which we published recently, the carotidoclinoidal ligament and the inferior paracellular ligament are both very constant, and it always has to be in your mind when you are doing these operations. And next, the inferior hypophyseal artery has to be identified. Again, understanding the cruroidoclinoidal ligament is key. And you can see this ligament comes from attaching in the middle clinoid and the medial wall and goes around behind the carotid, forming like a neck. That's why it's like a ring. This is a proximal ring, and goes to the anterior clinoid. And just when you cut all these fibers, at the back, you're gonna see the posterior clinoid and the interclinoidal ligament coming from it. So based on this anatomy that we studied, we described this stepwise anatomically-based technique of removing the middle wall of the cavernous sinus. The first step is always separating the two layers, entering the anterior wall, open it widely so you can see the carotid. And once you see the carotid and you open the cavernous sinus, you're gonna first see the inferoparasitaral ligament, which you're gonna cut. Behind, you're gonna find the inferohypophyseal artery, which usually you're gonna coagulate and transect. Then the medial wall needs to be disconnected from the floor. This same dura continues as the floor, dural floor. You need to transect it here. Usually go all the way to the level of the posterior gland and cut it next to it. And then you have to go superior and separate this from the dura that continues towards the diaphragm. And then superolaterally, you need to disconnect the cruroidoclinoidal ligament. If you do so, you end up with an en bloc resection of the middle wall of the cavernous sinus. Just to show you in some cartoons, basic principle is to do a wide exposure where you can actually expose the whole anterior wall of the cavernous sinus. The exposure needs to be very extensive. After we open the dura, we find the tumor, we do the interface between tumor and pituitary gland, remove the tumor, and then we inspect the middle wall of the cavernous sinus. You see in this case, there is some tumor invasion in the middle wall of the cavernous sinus. So next thing we do is we separate both layers, we open the anterior wall, then we disconnect the inferoparasitaral ligament and the artery behind, and then we can separate from the floor, separate from the clenoidal ligament, and we can finally remove the whole middle wall en bloc. And at the end, we're gonna see the posterior clinoid and the interclinoidal ligament. So those are the basic steps for the middle wall resection and the key surgical anatomy to perform it safely. I'm gonna show you one first case. Look at this tumor, which does not appear to invade the cavernous sinus at all, patient with acromegaly. You see, this is the middle wall of the cavernous sinus. Is it invaded? You would say no, based on imaging, right? But so let's see what happens in the operation. We do a wide exposure. We see the tumor growing down. And you see how we have extended exposure all the way lateral. The whole anterior wall of the cavernous sinus has been exposed up to the clenoidal carotid. So next, we are opening the dura carefully, and we find our plane between pituitary gland and tumor. These tumors are often soft, so you try, but you don't often remove it just in one single piece because they are so soft. But look at what happens when I remove the tumor. This piece of tumor is stuck to the middle wall of the cavernous sinus. If I use the suction, it doesn't come out. So my only way to remove it completely is separate both layers. You get venous bleeding. Then I open the anterior wall widely. This venous bleeding is easily controlled with hemostatic agents. Then I continue separating medial wall from anterior wall. This dura here is the medial wall, and this dura here is the anterior wall right here. So we separate one from the other. We're gonna be looking for inferoparasitaral ligament here, medial wall, anterior wall of cavernous sinus. That is the inferoparasitaral ligament and the artery. Inferohypophyseal, then I cut the dura along the base of the posterior clinoid. And this takes me all the way posterior and superior. And I keep going superiorly until I get to the cruroidoclinoidal ligament. And look what happens here. This is the tumor growing on the other side of the middle wall of the cavernous sinus. That's why you cannot remove it completely just by staying on the medial side. You have to remove the whole wall. Then we disconnect from the dura that continues towards the upper part of the gland. And there we have our complete en bloc resection of the middle wall of the cavernous sinus. And we can even see the tumor embedded in the fibrous tissue of the medial wall. What we do is then we send these pieces to histology to study them with H&E, but as you will see also with immunochemistry studies for transcription factors. So we published our first 50 patients that underwent medial wall removal. And these are cases that Dr. Garner and myself, we did together in Pittsburgh, cases from both of us. And we had no ICA injuries, which was the first most important step, was to prove that the technique was doable and was safe. And we did it with no injuries to the carotid. 4 patients at that point developed new cranial palsy, but in all of them, it resolved completely at follow-up. These are in the majority 6 nerve palsies, and they are because of usually packing that you place in the cavernous sinus to control bleeding. As you will see, this cranial palsy has become better in the next experience, but is one of the risks of this technique. Importantly, the medial wall was histologically confirmed to be embedded in 86% of the patients, which I believe is very remarkable. And in this early series, all except one of the patients were in remission, but this was a short follow-up. So we cannot still say this technique is providing superior results based on this, because we need longer follow-up. I'm gonna show you 2 of the cases that got complications from it. This was a case that was extremely difficult because this patient had Cushing's disease and bilateral medial wall invasion. In this case, the medial wall is pushed all the way lateral, all the way here and all the way here. And it requires opening both cavernous sinus, which increases the difficulty, of course. This patient got a post-operative clot, and then I had to take the patient back to the OR. He developed a 6 nerve palsy, and he recovered completely. And remarkably, this patient, as far as I know, is still in biochemical remission. Another patient with a non-functional adenoma got a small clot right here and a delayed 6 nerve palsy that completely resolved in just a few weeks. Now, what I want to share with you today are the results of doing the medial wall resection while I've been here at Stanford the last year and a half or 2 years. And what is very surprising to me while we reviewed this recently, and we plan to submit for publication soon, hopefully, is that in 92 consecutive adenomas, 53% of them require medial wall resection. This means more than half of the tumors I did, I actually removed the medial wall of the cavernous sinus. And this is to highlight how important is to incorporate this technique into the armamentarium of the pituitary surgeon, because about half of the tumors are gonna likely need this medial wall resection to get the best possible results. But it was also very remarkable is that the invasion rates we are seeing on the medial wall depend strongly on the cell lineage. And as far as I know, this has not been reported before. We can see here somatotroph adenomas, 22 cases, in 20 of them we did the medial wall resection. Now, when do I do a medial wall resection? I do it based on intraoperative observation. I evaluate the medial wall, and if I think that it's invaded, I see some tissue, I don't see a clean medial wall, then I'm gonna remove it. And then I'm gonna send it to the pathologist to confirm whether it's invaded or not. And as you see, the other adenomas, for example, gonadotroph, the rate of invasion is much lower, while the rate of invasion for somatotroph adenomas is very high. In 90%, I removed the medial wall. 77% total had confirmation of being invaded. As you see here, growth hormone adenomas are the most commonly invading the medial wall, followed by prolactinomas. And what is important also to highlight is that this has not been reported before. The adenomas, growth hormone adenomas, were reported to invade the cavernous sinus in about 30% of patients, but our experience is showing that 77% of these patients actually have invasion of the medial wall of the cavernous sinus. And more than 90% of you are based this assessment just on your intraoperative observation. And again, as we said, we confirm all this with H&E studies, but also with transcription factors based on the new classification of the World Health Organization for pituitary adenomas. Now, still 20% of our patients will remove the medial wall and it comes back negative. So is that a true negative or is that a sample error? I cannot tell. My impression is that some of these that came up negative is because our sample maybe was not good enough, or there is some technical error, or maybe actually it's not invaded. But usually you have a very good assessment during the operation when a wall is invaded and when it's not. You see, I want to just highlight here how for gonadotroph adenomas, these are non-functional adenomas, which is controversial whether removing the middle wall is indicated or not. It's not controversial for me, but it's controversial for other surgeons. But in this case, 8 patients I removed the middle wall, all of them had confirmation of the wall being invaded. So we are very good selecting which patients need resection of the middle wall of the cavernous sinus. I'm going to show you some cases. This is another growth hormone adenoma. And based on this, you cannot tell whether it's invasion of the cavernous sinus or not, or whether it's invasion of the middle wall or not, but we'll see during the operation. I always like to look at sagittal cuts on pituitary tumors because it gives me an idea of the relation of the tumor with the carotid artery and the compartments of the cavernous sinus, which we'll review shortly. So in this case, similarly, very expanded approach. The carotid is all exposed here. Anterior wall of the cavernous sinus is all exposed. The usual first steps, separate pituitary gland from pituitary tumor. We just debulk the part of the pituitary tumor in the sella, which is easy, and then we find a nice plane with the pituitary gland. But then I look at the middle wall, and it's clearly invaded, and this is not suckable. So I have to again remove the middle wall. So separate middle wall from anterior wall. I open the anterior wall really widely, and this is to me very important because I need to see the carotid. As I'll show you later, this is all about being comfortable working around the carotid artery and dissecting tumor directly off the carotid. If you're not comfortable doing that, then this becomes a much more challenging because tumors can be very difficult to remove. These middle walls. This, you see, the carotid is right here, and this is the middle wall. It's very attached to the carotid artery through all these ligament attachments. The tumor has been pushing the wall towards the carotid and is really attached to it. So you have to very carefully find all those ligaments and one by one detach them. Coagulate some, cut them, detach, pull carefully. You see the inferior hypophyseal artery right there. You need to coagulate and cut it. You are not going to be able to remove the middle wall in this case without cutting that artery. Once you coagulate and cut, I can start peeling off the middle wall of the cavernous sinus away from the carotid. And as I make my way up into the roof of the cavernous sinus, these are the fibers of the carotidoclinical ligament, and the tumor is embedded within those fibers, as you can see there. So it's amazing to me how these tumors are able to live within the middle wall and within the ligament fibers even. So now I'm going to move all the way up to the dura that forms the roof of the sella, and all the way back until I see this. This, what I'm seeing here, is dura, and is the posterior clinoid, and the interclinical ligament is going to be starting right there, which tells me I'm removing all the middle wall. And you see, this is the whole middle wall right here. And then medially, I cut it just next to the posterior gland. But this is the middle wall. It's all embedded by tumor. You see intercranial ligament, posterior clinoid, posterior gland, and the whole thing has been removed. And this makes a dramatic difference in the outcome of these patients. This patient is in biochemical remission, and if we hadn't removed this middle wall, she would have not been on biochemical remission. Another example, this is, this tumor is touching the carotid. When I see this, I'm suspecting now, based on my experience, that this tumor is definitely going to be embedded in the middle wall of the cavernous sinus, so I go prepared for middle wall removal. This also makes a difficult case because the carotids are almost kissing, close to each other. And we know acromegalics have this problem that operations are more difficult because of the tortuous carotid. You see how the tumor is invading towards this region, which we call the superior towards the posterior compartment of the cavernous sinus. So similarly, we do our exposure, and in this case, it's more difficult because of the anatomy in this particular case, but I have to really do the approach I need. I cannot just settle with a small approach. I need to really expose the whole carotid, and in this case, it's difficult. That is a Doppler I always use for surgeries, and I always start by exposing the anterior wall of the cavernous sinus as the safest point, but then I'm going to follow the carotid medially. And you see the loop that the carotid makes right here, and this is the carotid just covered by periosteal dura. But finally, difficult exposure, but I'm able to remove all the bone and completely expose the carotid artery and the anterior wall of cavernous sinus. So similarly, first step, let's find the plane between the pituitary gland, right here, beautiful plane, from the tumor. Then remove the tumor in the sella. And this is the middle wall right here. some of the arachnoid herniating down. This is the dura on the floor, which often is embedded too, and that's much easier to remove. Shrinking the arachnoid. And then here, this becomes very difficult because the carotid is looping medially, and there is little venous space for me to work inside the cavernous sinus. But still, I'm able to access the cavernous sinus, and I start peeling the medial wall from the carotid artery here. And this here is medial wall. And I have to gently separate this medial wall from the carotid artery. We just saw one inferior paracellus ligament right here. And I need to keep progressing and separating anterior wall from medial wall all the way back to the level of the base of the posterior clinoid process, which is right here. And this is the posterior gland right here. In this case, there is no distance between posterior gland and carotid just because of how loopy is the carotid. And this is the medial wall. It has tumor inside. I just removed some of that tumor inside the medial wall. And I have to carefully, progressively separate this medial wall. You see this is a tedious job because you have continuous venous oozing that it's easy to control in most cases, but you have to, stop multiple times to do hemostasis so you can see the anatomy, you can see the ligaments. You see a strong inferior paracellus ligament right here. And in this case, the invasion goes high. So I'm gonna go into the clinoidal space right here. So I can get the clinoidal ligament, choroidoclinoidal ligament from above and from below. I have to surround it. So this is the choroidoclinoidal ligament right here. And this is the clinoidal space I just opened. And disconnecting the choroidoclinoidal ligament. So I can remove this portion of tumor. You see this yellowish part, that is tumor embedded in that medial wall and around the choroidoclinoidal ligament. And once you disconnect it, this becomes just beautiful because I can just gently pull the tumor out that is embedded in the cavernous sinus wall. I stop because I need to see the inferior hypophyseal artery. And when I'm in the posterior compartment, towards the posterior of the carotid artery is where I think about the inferior hypophyseal. And that's for the inferior hypophyseal artery, which we transect. And after that, we can mobilize it further. And you see how this tumor is, again, embedded in this ligament. And if I don't cut this ligament, it's impossible to remove this tumor. But I know the anatomy. I'm confident of what I'm seeing. I know what I have to do. And finally, I can remove this tumor. You see some nice chunk of tumor here. And you see the last ligament attachment right here. I can now transect it and even pull that last piece of tumor that was embedded behind the carotid artery, but it's still embedded in the wall. And with this, we achieve a complete tumor resection. This is the base of the posterior clinoid. And I'm even going to remove some remaining medial wall, perhaps here. And I see the lining all the way to what is here, which is Durello's canal. And that dura looks now nice and clean. I dissect around the posterior clinoid. Inferior hypophyseal artery more proximally. I cut and coagulate. And I cut this dura here. So I can remove the tumor completely. So as you see, this is entirely cavernous sinus surgery. This is the interclinoidal ligament. Beautiful view from the posterior clinoid. When I see this, I know I have removed all the tissue that forms the middle wall of the cavernous sinus. This patient had a post-operative day 1 growth hormone level of 0.25, which is equivalent to almost certain biochemical remission in the long term. So as you see in these cases, the resection of the middle wall is so much about understanding the anatomy and being comfortable dissecting the carotid artery within the cavernous sinus and even in the clinoidal space. So you are going to be working around this carotid continuously, and you're going to be working segment by segment of the carotid. You're going to be transecting ligament by ligament, so you can actually do a complete removal of this tumor invasion. When we look at the NOS grade in our series and the rates of cavernous sinus invasion, this is an excellent paper from Ted Schwartz at Cornell, where just based on the NOS classification, they say, cavernous sinus invasion is about 30%, which is what is accepted because it's NOS grades 3 and 4 mean cavernous sinus invasion, but 0, 1, 2 do not. However, what we are seeing here is that in our series, this is a dramatic finding because, grade 0, 2 out of 5 patients had a positive invasion of the medial wall, 40%. In grade 1, 83% of the patients had invasion of the medial wall of the cavernous sinus. In grade 2, universally, all of them, 5 patients, 5 out of 5 had invasion of the medial wall of the cavernous sinus. And of course, grade 3 and 4, by definition, they're invading the cavernous sinus. So the NOS grade really is not useful for us to predict whether there is invasion of the medial wall of the cavernous sinus. It is a great classification, but it's a radiologically based classification, not anatomically based. That's why we also studied carefully the anatomy of the cavernous sinus, and we describe the compartments of the cavernous sinus, because this is what makes, in my opinion, working in the cavernous sinus safer and more efficient. We describe 4 different compartments. Based on the location of the horizontal cavernous carotid, we can have a compartment above, superior compartment. We have one behind, posterior compartment, and one below, inferior compartment. The newer NOS classification is now considering superior and inferior compartments differently, and that makes sense, but they are not acknowledging the posterior compartment, where very often we have disease and where we need to become comfortable working to achieve better results in these patients. The anatomy we need to understand for the superior compartment is highlighted here. In the superior compartment, we have the interclinodal ligament, as we saw before, and above it, we have the clinodal triangle with the carotid artery, clinodal ICA, and inferior or lateral, we have the oculomotor triangle with the oculomotor nerve running. This is key anatomy. The interclinodal ligament is a reliable landmark for surgery. The posterior compartment is the one that is behind the carotid. And behind this carotid, what we find is the 6th nerve at the bottom, on top of the petrosal process of the sphenoid bone. And the inferior hypophyseal artery is also found here in the transition between superior and inferior compartments. Now, in the inferior compartment now, we are working through the anterior wall of the cavernous sinus. And what we find below the horizontal ICA is the 6th nerve and the sympathetic nerve running towards the 6th nerve. So again, also very important, relevant anatomy to remember when we work inside the cavernous sinus. And finally, we have our lateral compartment, which is lateral to the carotid, the area where we are most carefully working. And if we have a soft tumor, we can do significant work in this area. But if it's a more fibrous tumor, it becomes more dangerous for the cranial nerves. I'm going to show you a few examples. This is an adenoma, non-functioning young patient that is invading, as you see here, superior compartment towards posterior and a little bit of the inferior. So that's the way I look at these MRIs, looking at which compartments are being invaded. So as always, we do a wide exposure, clinodal carotid, all anterior wall of the cavernous sinus. So we're going to open, remove the tumor in the sella, and now there is tumor in the cavernous sinus. So then we open the anterior wall. Again, it's key to open this anterior wall really widely because I want to see the carotid, because I want to be able to dissect tumor off the carotid directly. This is a soft tumor, which makes things easier. And then we start identifying one inferior hypophyseal branch and a second one right here. And remember, these branches are anchoring the carotid artery. You are mobilizing the carotid laterally, and to do so, you need to sacrifice these branches so you can move the carotid more efficiently and get more space to go into the cavernous sinus. And remember the anatomy we just described. This is here the interclinodal ligament. I've seen even experienced surgeons thinking this is the 3rd nerve, but this is the interclinodal ligament. The 3rd nerve is below it. Is this prominence right here. Now, this is the middle wall of the cavernous sinus, grossly invaded, but still part of it is there and it has to be removed. So now we're moving the middle wall of the cavernous sinus because we're gonna make our way into the inferior compartment of the cavernous sinus. Next thing I'm thinking is carotid. short vertical segment of the carotid right here. I open the anterior wall more, and I use my electrical stimulator because I'm thinking about sixth nerve in this area. And I make my way around the carotid. So I need to, again, do a beautiful dissection of the carotid to remove all the tumor around it. And then the sixth nerve is going to be right there. This is our sixth nerve. Stimulates very nicely. This patient did not have any sixth nerve or any other oculomotor nerve palsy. And then I can make my way up towards the cranial segment to remove remaining tumor in the posterior compartment again. And at the end, we achieve, this is just moving last bits of the middle wall of the cavernous sinus. And at the end, you see the carotid is completely dissected, sixth nerve laterally. Any remnants that could be stuck to the carotid, I just coagulate. And this patient gets a nice complete tumor resection, which in my opinion is important for many of these patients for long-term remission or for long-term, tumor control. Another example, more widely invaded. In this particular case, I'm going to jump. This case is more difficult because the carotid is very tortuous. And I want to show you two things from this case. One, again, the third nerve is up here, and there's the intercranial ligament. And I know it is the third nerve because it's below the intercranial ligament, above is cranial space, and cleaning both cranial space and oculomotor triangle in the superior compartment. And then I'm going to move here because I want to show you in this area, working towards the inferior compartment. There is tumor invading this compartment. And you see this is the sympathetic nerve right here that is going to be joining the sixth nerve. If you stimulate it, it's going to tell you it's the sixth nerve, but it's not. Stimulate because it connects with the sixth nerve. And then this is tumor we're peeling directly off the carotid artery. And as we said, if you're going to commit to this work, you need to be very comfortable working with around the carotid artery. And you can see another beautiful view here. This is the petrosphenoidal ligament or Gruber's ligament right here. So sixth nerve is going to be just underneath. But here, look what is happening here. I just got a hole in the carotid artery, right at the origin of the inferior hypophyseal. So that could be dangerous, but I'm able to see it, and I seal it with the carotid bipolar, and no further issues, no further bleeding. And look how this carotid is looping very medially, and this makes this carotid dissection more challenging and more difficult. And you can see this patient actually got a partial third nerve palsy, mild, very mild, that recovered in just a few weeks. Complete tumor resection, as we can see in the MRI. Now, other functional tumors, prolactinomas. This is a patient that had an operation for apoplexy years ago and presents with this tumor that has grown. He's on maximal medical therapy. The prolactin keeps raising. And now the chances are we either do radiation for this tumor or we do an operation trying to remove all the tumor. This is a challenging tumor because of the invasion of the cavernous sinus. But I want to show you with this case something very interesting. And you see, this is the anterior wall of the cavernous sinus I'm just opening. And what you see here, this is the middle wall right here. So the tumor is medial to the middle wall and is pushing the middle wall lateral towards the carotid. So I can actually remove the part in the cella very easily. But the problem is the tumor is actually, again, growing in the middle wall of the cavernous sinus. And then this becomes a challenge. So I'm working, removing just the soft portions of tumor. And I'm trying to detach this middle wall from the carotid. And it becomes very difficult. But carefully, I can dissect the wall off, cut the attachment sharply. It's another tortuous carotid. And in this case, the tumor extends towards the clinoidal space, and the imaging showed that. And I'm becoming, more and more knowledgeable of the anatomy of the clinoidal space from an endonasal perspective. And this is also a very key knowledge for safe operations in this area. Understand the rings, the clinoidal carotid becomes very important. So here we disconnected the intercranial ligament, and you can see through the dura, we're in the oculomotor triangle. What you see there is the PCOM artery. And I'm using my stimulator to stimulate the third nerve, and you see something white here. Now you might think that is the third nerve, but I know it's not the third nerve. I know it's the interclinical ligament. The third nerve is going to be just below. And here I have to do this tedious work of a piecemeal fascial removal. The tumor is invading the clinodal space and proximal dural ring right here. So I'm cutting the proximal ring. And I'm detaching the proximal dural ring from the clinodal segment of the carotid artery. But still I have tumor lateral, working with angle scopes. And again, this tumor is stuck to the carotid. What you see there, that white structure, that actually is what is called the anterior petroclinidal ligament, is the lateral limit of the oculomotor triangle. Again, it's not the third nerve. The third nerve is down here. And clean all this superior compartment of the cavernous sinus gently, and at the same time trying to preserve the third nerve, which stimulates very well at the end of the operation. This is the whole carotid, and I don't see any residual tumor, intercranial ligament, coagulating the remain of the intercranial ligament, carotidocranial ligament. And then this is a beautiful view. This is the supraclinidal carotid going to the distal ring. And this is the PCAM, and the third nerve, it will be just below. With this aggressive resection for this invasive resistant prolactinoma, this patient got a prolactin day, also day 1 prolactin of 8, with no obvious residual on the MRI. He's off medication, and as you see here, he has intact cranial nerve, no double vision at all. So to finalize, I want to show you that in this case series of medial wall resection tumors, we had no ICU injury, which is excellent. And 2 patients had transient diplopia ICU, one of them, but they recovered. So it's really very low morbidity for this operation in experienced hands. And I want to show you, although this is still very preliminary, how this technique can actually really impact our outcomes, especially for functional tumors. You know, in our series of 25 growth hormone adenomas over the last year and a half, we had the mean postoperative growth hormone level was 1. And all of them except 1 patient were below 2. And this is an indicator of good prognosis. If you compare with other series, with the excellent group at UVA, for example, their postoperative growth hormone level was 2.2 plus 3.5. Ours is 1 with standard deviation of 0.75. So all immediate growth hormone levels have significantly improved by doing this resection technique. Our patients' IgA1 levels are dropped and are have normalized in 91% of our patients. Again, this is not just a short-term follow-up. So we need longer follow-up to make strong arguments here. But to this point, all of our patients are in remission, including the 2 that are not they are in remission with adjuvant therapy. 1 got radiation, the other one is on medication. Our own series, when I was in Pittsburgh, our resection rate, we were so frustrated because they were in about 50%. And this has improved, and we're able to improve this through surgical innovation, introducing the medial wall resection technique. So I think this is extremely promising. And it's not only my experience or the experience of, at Stanford or at Pittsburgh, it's also the experience of, for example, this Japanese group. They have an 85% remission rate. This other group is also in Japan, Dr. Nagata. Only 12 patients, but 91% remission rate when they do this medial wall removal technique. These are more recent publications. So this is a very promising technique. So in conclusion, more than half of all pituitary adenomas may invade the medial wall of the cavernous sinus. And importantly, invasion rates depend on the tumor type. Growth hormone adenomas in particular invade the medial wall of the cavernous sinus much more often than previously reported, and more often than other tumor types. The removal of the medial wall may dramatically improve the remission rates. In acromegaly, we are seeing improvement from 50–60% to more than 90%, although we need longer follow-up. And medial wall removal requires, dissecting the cavernous and clinoidal ICA, but complication rates are very low when it's done by very experienced surgeons. So this makes me think pituitary tumors should ideally be treated only at highly experienced pituitary centers by pituitary surgeons with ability to remove the medial wall of the cavernous sinus. Removing pituitary tumors in the community, you know, the outcomes are necessarily going to be worse than, especially for functional tumors, that if they are done at centers with a lot of experience. And I want to finish by, you know, sending this very important message to you. Know, the work you see here is the evolution of many years of commitment and work, both in the lab and in the OR. We need to respect the learning curve. Don't please see my talk and see, you know, nice resections and good outcomes and think that, you know, you're gonna go like here and you're very confident you're gonna do it. This is, you know, difficult, and it requires a lot of training and expertise. You need to go through this learning curve to get to the point where you become comfortable with these techniques. This reminds me, like, you know, I visited recently Yosemite National Park, and you see El Capitan, and, you know, I took a picture of this black dot right here. This black dot is a guy that is climbing this wall, and this requires a lot of training, and you can become a true master of this. This guy, this is Alex, and he can climb this in 3 hours, freehand technique, solo technique. Absolutely amazing. But don't try to do this in the OR. Don't try a solo technique when you don't have enough training in your hands, because you can go up here and have a dramatic fall and have real complications from this operation. Sometimes these type of operations are like going up El Capitan. You need to be very well trained and fully committed to this type of operation. But if you do it, you can end up all the way to the top, happy like Alex, and safe. So I will finish my talk here. I want to thank again the organizers for inviting me. I'll be happy to take any questions from the audience. Muchas gracias. Thank you.
Dr. Fernandez, thank you very much for such a wonderful lecture, as you always do. I'm sure all the audience has learned from your vast experience. Right now, we have a few questions from the public. I will read the questions to you. So Andres Almendral has a question. In COVID era, what are you doing to limit the contamination by aerosols?
So that's a good question. So, you know, very early on at the beginning of the pandemic, early March, you know, we became very worried about the risk of intraoperative transmission with endonasal surgery. And it is a real concern that we all need to have. But with proper preventive measures, we can do this very safely. I haven't changed my technique at all. The only thing we have incorporated is doing testing in patients. So we have a protocol where we do pre-operative testing for all patients going into surgery. And this is done 2, 3, 4 days before the operation with PCR technique. And then the same day of surgery, the same morning, they get what is called a rapid testing to just confirm that they are negative. And then we go to the OR, and we believe we are very safe with that protocol.
Thank you, sir. Next question. Do you think a large number of recurring cushion disease, even after a hypophyseectomy, lie in the cavernous sinus walls?
Yes, I do think so. And, you know, the experience of Oldfield is the best that we can find, of course. And he saw that, and he demonstrated that a number of patients, even in his own series early on, they were recurrent tumors because of residual in the middle wall of the cavernous sinus. Yes.
Thank you, sir. Al-Hussein Nang is asking, cavernous sinus medial wall resection only in functioning adenomas? You showed non-functioning pituitary adenomas? He's asking if you can do it for non-functioning pituitary adenomas.
Yeah, I mean, this is a controversial topic. You ask what I do. I do remove the middle wall of the cavernous and also non-functional adenomas, because I know I can do it very safely with very low risk for complications. And I think it's better for patients. They get a better long-term tumor control, and you can avoid medication, or you can avoid radiation in the future. Now, should it be done across the board? I don't think so. It should be done only by those that feel really comfortable doing. If you look at our original paper on middle wall resection, our first cases were all of them functional tumors. We only started doing non-functional adenomas when we became, good at the technique, but not before. Now, I think this is all subjective. So every surgeon has to decide what is their balance between risk and benefit. And that is different for every surgeon, depending on their training, expertise, etc. So My standards are different than others, and they might be different for different pathology, depending on your expertise. But if you ask me, yes, I do remove non-functioning tumors.
Sir, next question. Cavernous sinus approach after radiation, is it possible?
Yes, of course, it is. It is likely more difficult. I've done a good number of them. It's difficult to evaluate whether it is more fibrotic or it is always more concerning and likely more difficult, but it can be done.
Sir, next question. Do you do carotid occlusion test in case of injured the carotid? I think he's asking if for the carotid injury you will use a carotid test occlusion.
So I don't do pre-operative balloon tissue occlusion for these cases. I do not. And the only case that I do a BTO before an operation is where, you know, rarely for adenomas. It could be for adenomas, but usually for tumors encasing the carotid that I need to go for an aggressive resection, more commonly for chordomas, perhaps, maybe some meningiomas. It's possible some adenoma. I don't remember an adenoma on top of my hand that I did, but I use it very selectively.
Thank you, sir. I think you already answered this question. Felipe Constanzo asked, he said, great presentation, Dr. Fernandez. We know that the learning curve for endoscopic endonasal approach is pretty steep. Is the curve steeper for medial cavernous sinus resection?
Yes, absolutely. I mean, you probably heard Dr. Garner. I know he talked about the learning curve and the levels to the learning curve, and you absolutely have to respect that. Medial wall resection is equivalent to carotid dissection, which is level 5, is the highest, most difficult level. So that's why you should only do it when you are very experienced, not before.
Thank you, sir. There's a question about intraoperative neurophysiological monitoring. Do you always monitoring 3rd, 4th, and 6th nerves?
Not always. I do selectively. You know, for medial wall, I don't typically do, because if I don't expect to be working within the cavernous sinus and taking tumor around nerves, then I would not use it. But if I have, you know, a NOS 4 or a NOS 3BA, you know, if I have invasion, better say, of the superior compartment, I monitor 3. If I have invasion of the posterior compartment or inferior compartment, I monitor 6, or I monitor 3 and 6. 4th is less useful, and I actually stop monitoring because it doesn't, you know, I just do 3 and 6.
Sure. I think you just answered this question. Did you ever had an ICA injury or a septal aneurysm secondary to this procedure?
No, I never had an ICA. You know, not doing the middle wall resection and doing endonasal surgery. I had one in 2009 while I was in training in Pittsburgh, since doing a really bad chondrosarcoma. Since then, I have not had a carotid injury. I've been very careful, but at the same time, I've been doing, you know, surgery around the carotid all the time. So you can do this type of surgery with a very good safety profile, but you have to do it so carefully and so meticulously to prevent that. Now, let me touch wood somewhere around me, because it will happen. You know, all of us going into this business, we need to be ready to deal with a carotid injury because it can happen anytime. But if you follow several principles, I think you can keep that risk really, really low.
Sure. Next questions. What is the long-term outcomes in these patients who had resection of the medial wall tumors versus those that didn't, but were monitored clinically and had radiotherapy post-op for residual tumor?
You know, I wish I would know. We don't have long-term data on this. This technique is relatively recent. I mean, you've seen the experience of other groups, especially the Japanese surgeons, which are phenomenal surgeons in skull base and pituitary, and they are showing excellent revision rates. That's what I'm seeing in my patients. I can tell you that the endocrinologist that I work with, Dr. Kat Nelson, he's world-renowned in acromegaly. He wrote the guidelines, one of the most respected in the field, and he's been very happy and very surprised on how the outcomes have changed when I started at Stanford and we started doing all these more aggressive resections. You know, we have only 2 of our last 25 patients in medication, and that is pretty remarkable.
Sir, next question. What would be the role of gamma knives in relationship to the other questions? Is there any role for gamma knife for residual of the
I do think there is a role. Now, the role would be different depending. If you ask what is the role in my practice, I reserve gamma knife for patients that have already tried an operation like the one you see. I always prefer to go with a surgical indication first. I think I can resect the tumor because it's a more effective, long-lasting effect than radiation. And radiation has side effects too. But there are certain cases where if the tumor recurs after doing an aggressive resection and I think I cannot do any better, then radiation is a good option.
Muna Erkami is asking, how did you manage the bleeding of 1,200 milliliters as it happened in one case of your series?
Well, that's the same way you manage blood loss in the OR. So with the blood transfusion if needed. I believe that was an early case in Pittsburgh. I think it was that Cavernous Sinus case, that Cousin case with bilateral Cavernous Sinus invasion, where both Cavernous Sinus were open, and usually bleeding from the Cavernous Sinus is easy to control with gentle packing, but there could be cases, especially I found that bilateral Cavernous Sinus invasion are more problematic because as you work on one and you occlude one, the other one is getting all the flow, and there's a lot of flow on that other Cavernous Sinus. When you work on that, you get more bleeding. So it's rare that we have, all patients very rarely, actually have a look into it, but I doubt any of the patients in our series here at Stanford have got any blood transfusion.
Thank you, sir. In solid adenomas, when you decide to stop the resection maneuvers?
Can you repeat that?
Yes, sir. In solid adenomas, when you decide to stop the resection?
So, solid, it depends on so solid adenomas, you just need to do the right exposure for them, and you need to change your technique a little bit. You cannot just suck them. You need to use either a device to debulk them, or just need to go around it and remove them. So it's more difficult, but it can perfectly be done. Now, different is an adenoma that is very fibrous and is completely stuck to the carotid, and you cannot peel it off. And in those cases, or some others that are so invasive, NOS4, they're all around the carotid and they are fibrous. And no matter how good you are and how well you do it, there is always going to be some residual. So sometimes you just need to give up and you have to leave some residual. It happens sometimes. What I do usually is I coagulate those remnants of tumor by the carotid, hoping that that will be effective.
Thank you, sir. I think we have time for a last question.
No problem.
They're asking, I have some questions about the set you need for the resection. I just looking for it.
The what? Say again?
The surgical tools that you use. What skull-based endoscopy set do you recommend to acquire for this kind of surgery?
So I saw, and I started my conference with my conflict of interest. So I use a set of dissectors that I designed. Actually, Paul Garner, I believe, and the Pittsburgh team designed some in the past, and I just modify some of them to tailor to my needs. So there is as you see, curettes are not the right instrument to this type of surgery. I know pituitary curettes is the main instrument for most pituitary surgeons. I have just one pituitary curette in my set, which I rarely use. What I use is dissecting instruments that are like roton dissectors, and they are extendable, so you can tailor the length of them, because roton dissectors are too short sometimes to go through the nose. They are not the right instrument. So we need these modified dissectors. And as you saw, a key instrument for this operation in particular is the right angle knife, because it has a blunt tip, but the upper part of it cuts, is sharp, and then you can put into the cavernous sinus and cut, or near the carotid and cut. So it's a very useful, it's a key instrument, in my opinion, to work in the cavernous sinus.
Thank you, sir. Just the last question. Any tips on finding the plane between adenoma and normal pituitary gland?
Yes, I mean, there are tips there, of course. Of course, with experience, this becomes relatively easy. But so the things you look for is, the color. The tumors are more pale. The gland is well vascularized. You can see the microvascular pattern, and the gland is well vascularized. It's pinky. It has little vessels in the surface. Tumors do not have that. Now, very often, when you open the dura, you find what you see is all gland, and the tumor is behind a layer of pituitary gland. So you have to go and open that first layer of pituitary gland, and immediately behind you're going to find the tumor. You saw that in my case is how you can find that very accurately. But it's just looking, is the appearance, is the microvascular pattern, is the color, is also the texture, the consistency. I can hear you.
Dr. Fernandez, on behalf of CIEN, I'd like to thank you again. This has been a wonderful lecture. We are really grateful and honored for your participation in the 2020 IWBNC. More than 3,000 people were registered to this Congress from over 114 different countries.
Wow.
You are more than welcome to stay tuned to watch more lectures from other speakers. In a few minutes, we will have Dr. Roger Hardle for 5 principles of spinal minimally invasive surgery, target, technology, technique, training, and testing the boundaries. To get the link to this upcoming conference, please follow the link pinned on the chat screen or check the agenda to our website, cnhus.com. Thank you very much, Dr. Fernandez.
Thank you.
Have a good day.
Okay, enhorabuena.
Hasta luego.
Yeah.